Yes. Hi, Dr. Wiseman. How are you?
Good afternoon, Carin. How are you? Thank you.
I'm doing very well, and I wanted to take the opportunity to say thank you for having this interview and sharing with us some of your experience about adhesions and chronic pelvic pain.
Okay. Look forward to talking to you. What can we do for you?
Yeah, I really enjoyed meeting with yourself during the Alliance for Pelvic Pain in Bethlehem, Pennsylvania earlier this year, and we had a great conversation while we were there, and I thought it would be wonderful, like I mentioned, to share with some of the other patients. So in your experience, you're quite the expert on how these pelvic pain conditions are related and how they're related to adhesions.
Okay.
Can you give us an overview on adhesions and how that's all related?
Okay, thank you, Carin. Yes, I certainly remember that meeting or the event in Bethlehem organized by Dr. Eckenberg. Fantastic event, and hopefully he's going to do it again. But let's talk about adhesions. My background is, first of all, I just want to emphasize I'm not a medical doctor. I just play one on the internet. I have a PhD in experimental pathology. I'm a pharmacist in England, and I've been working on adhesions for many years. When we started working on adhesions, when I started working on adhesions, what were adhesions? Adhesions were, and still are, abnormal connections between tissues that should not be normally connected. So a piece of bowel is adherent to another piece of bowel or to part of the female genital system or other organs in a way that is not normal. And those were believed to cause and understood to, still today to cause bowel obstruction, functional impairments in the reproductive system, because the fallopian tubes, for example, can get kinked up, the ovaries cannot release their eggs properly, and so on. So it causes functional infertility impairment. And the last thing that, more controversially, is adhesions cause pain. And many people think they don't cause pain, but we clearly understand that the patients with adhesions do have pain. The exact relationship is not known. But the focus of the work that everyone was doing 25 or more years ago was to try and prevent the adhesions from occurring or from reoccurring if the surgeon went in, cut the adhesions, and tried to prevent them coming back again. And certainly that remains a worthwhile goal for surgeons even till today. But the problem then remained was only a surgical problem, meaning there was an adhesion, it was something that shouldn't be there, and the treatment for it was to cut it out and to stop it from coming back again. And again, as important as that may be, what we understood when I started the International Adhesions Society back in about 1998, we started to speak with patients in a much more detailed way about their condition. And we understood that their condition was way more than just bowel obstruction. I don't want to say just bowel obstruction, that's a very serious issue, but just bowel obstruction and just pain. They had many more symptoms and impairments in their bodily functions. And so as we started to ask more and more questions, and we started to get in contact with the pelvic pain groups and the interstitial cystitis groups and other groups, we started to ask questions of the adhesions patients that no one had ever asked them before. And one question that I started to ask about 10 years ago was, do you have any problems with your bladder function? And the answer most commonly was no. And then I would probe a bit further and say, well, how many times do you go to the bathroom every day? And a patient would say, well, 15 times a day. And I would ask them, well, don't you think that's a little bit excessive? And then on reflection, they would say, yes. I said, let me ask you this. Does it hurt when you go to the bathroom or just before you go to the bathroom? And again, the patient would say yes. And then the $64 million question was, has anyone ever asked you these questions before? And in 99% of the cases, no one had ever asked the adhesions patients whether they had had bladder problems before. They had asked them pretty much if they had had bowel problems, because everyone sort of knows that adhesions could cause bowel obstruction, but no one had ever asked them about bladder function. And certainly very few people had asked them about their sexual function either, and that's a question that we can talk about a little later. But in terms of their ability to be intimate and to have sexual relations, no one was asking those questions either. And so we set about to understand what was going on here, and we realized very quickly that the patients that have adhesions become very similar to patients that in terms of their chronic pain, become very similar to patients that have had chronic interstitial cystitis or chronic pelvic pain that doesn't have a bladder component, or endometriosis for many years. And there was a growing body of literature in the medical literature to suggest there was a lot of crossover between patients that had endometriosis and patients that had interstitial cystitis and patients that had irritable bowel syndrome. And so we added to that list adhesions patients. Okay, and so we saw that there was a tremendous crossover, and we documented that. And one of the big things that we did, and I'm holding up her paper now, which you can get on the internet. There'll be a link posted at the bottom of this section. We published this paper called "Disorders of Adhesions or Adhesion-Related Disorder: Monolithic Entities or Part of Something Bigger, CAPPS?" ? And so we understood that really, if someone has been in pain for such a long time, it almost doesn't matter anymore whether they started off with adhesions, whether they started off with bladder issues, whether they started off with endometriosis issues or bowel issues or what have you. Okay, it almost doesn't matter anymore, because once the patient has been in pain for such a long time, the pain itself becomes its own disease. And you know, Carin, from everything you've studied, and certainly from that weekend in Bethlehem, that there's a phenomenon called centralization. And many people are talking about it now. But 10 years ago, people weren't talking about it. Very few people were talking about it. And so we saw that there's a tremendous crossover between these conditions. We called it complex abdominal pelvic and pain syndrome, CAPPS, simply because we wanted to get out of the constraints of compartmentalized medicine. In other words, patients who were only, or thought they were only bladder patients, were only going to get treated by a urologist, and none of the other issues were going to get looked at. Patients who were only, quote unquote, endometriosis patients were only going to get treated by a gynecologist, and so on, with pudendal neuralgia, a neurologist, with lower back pain in the sacroiliac joint, perhaps by a rheumatologist or an orthopedic surgeon or someone like that. And so we saw the need to remove ourselves from compartmentalized medicine and say we have to have a multidisciplinary approach. All of these patients, they may have started out their path in a different way, but they're pretty much ended up in the same way, and we have to treat them in a multidisciplinary, holistic manner. So that's how I got into this whole area. And then to just quickly understand what the adhesion is doing specifically to give patients pain. Well, we're not entirely sure. One certain reason is if someone has an adhesion, the adhesion could pull something, it could constrict something, it could reduce blood flow to something, and those are all things that could lead to pain. And if that's left unchecked for many months or years, that could become chronic, and once it becomes chronic, then there's crossover between the initial side of the pain and all the other things that are going on in the pelvis. Okay, that's the first thing. The second thing is the patient has surgery, which inevitably they will. The surgery is going to cause more damage. It's going to cause damage within the tissue to nerves that are underneath the level of the adhesions, which we're not even talking about. It's going to entrap the nerves with fibrous tissue, and all of those things are things that can cause pain or can trigger pain or can sensitize to pain. So I hope I've answered the question. Probe me if there's some parts that I missed out there, Carin.
No, you absolutely covered it, and if you didn't mind, I was going to quote you. There was a sentence out of your article that you just referred to that I think is a good endpoint to what you were just discussing. You wrote that, in fact, nerve endings have been found within those adhesions.
Right.
And I think that is a big piece of the mystery here, is if you remove part of the, but not all of the adhesion, that there could still be some nerve endings entrapped inside.
Right.
And it makes a lot of sense to me now why there's a lot of these pelvic pain-related issues.
Right, exactly. And it's only going to get worse. And as more procedures get invented or refined, for example, there's a whole bunch of procedures, as you know, to implant certain types of mesh, transvaginal mesh to deal with issues with prolapse of organs into the uterine cavity, or uterine prolapse, or bladder prolapse, or bowel prolapse into the vaginal cavity, and meshes are placed there, and they're placed in an area where there's just a mass of nerves, and fibrous tissue can develop around those nerves and entrap them, and no wonder those patients are getting pain. And other kinds of procedures where there's other kinds of meshes, hysterectomy. Between 12 and 15%, it's estimated, of all hysterectomies, that's about 70 to 100,000 hysterectomies a year in the United States, are done only for pain. Okay, and the evidence as to how this hysterectomy prevents pain or treats pain is very sparse. According to a recent government-sponsored report at the AHRQ, which is a government agency, sponsored a report, they concluded that the evidence for hysterectomy helping with pelvic pain is, I think the words they use are, insufficient to comment. So there's really not much data on that. But what we found, again, in our study, we've studied in this paper over 600 patients, American patients, and we compared whether they had a hysterectomy, what happened in terms of their pain and other symptoms in patients that had a hysterectomy or that didn't have a hysterectomy. And certainly, once the patient has had a hysterectomy, it seems they go off the cliff in terms of all the symptoms that can occur, the bladder symptoms, the bowel symptoms, the painful intercourse symptoms, and so on. And so, why is that? Well, you're doing so much more damage to all the nerves down in that very delicate area, and all those nerves interact, and so pain that may originate, let's say, in the vaginal area, crosstalks with a nerve that comes from the bowel area, or crosstalks with a nerve that comes from the sacroiliac joint, for example, or the pudendal nerve. And once that crosstalk occurs, it's like the old days, if anyone remembers picking up the telephone and you could hear your neighbor speaking on the line because there was a cross of wires that occurred in the junction box somewhere down at the end of the street. And this is exactly what happens, we believe, in terms of pelvic pain, why there's so much overlap between endometriosis, interstitial cystitis, IBS, and adhesions, and all these other things because of this crosstalk. And so if you do some damage down in that area with a hysterectomy, then you're going to make that worse. Of course, some patients really need a hysterectomy. There's some real indications, cancer and so on, where there's really not much choice in the matter. But if we can be more judicious for using other methodologies to avoid hysterectomies where possible, we should do so, and avoid meshes where possible. So anyway, so that I hope answers that question.
Yeah, absolutely. And I think you're about to start talking as well on some of the other pain management techniques. As you know, all of these surgeries and all these conditions and how everything is interconnected to create this overall picture of a very chronic and very complex pain disease. And I know a lot of times, these women, these men, they're seeing a myriad of doctors and having different treatments and being treated by 20 different doctors, but it's all one complex component of pelvic pain.
Right.
What are some of the other ways of treating these conditions outside of just some of the pain management, such as opiates?
Okay, so I think again, not being a medical doctor, but at least what we've tried to do is, first of all, guide patients to centers where there is a multidisciplinary team to fully assess and treat the pain. Okay, so obviously there can be some serious organic reasons for the pain, cancers and tumors and other functional issues that certainly need to be addressed. Okay, so let's not forget those. But beyond that, there are other reasons for the pain. I mean, the pain is very serious. I'm not trying to diminish it, but the first thing is, I think the patient really needs to try and see a specialist who specializes in chronic pain, chronic pelvic pain, that is, and who has in their team, either on site or available to them through very close working relationships, one of the following people, and I may miss some people out on the list, but certainly you're going to need a gynecologist or a urogynecologist, and if you don't have a urogynecologist, obviously a urologist. A surgeon should certainly be on the team. Pain management doctors should certainly be on the team. Physical therapy is very, very important. I cannot stress that more, and there are many a growing number of physical therapists that are trained in pelvic floor and pelvic pain physical therapy, and they have a higher qualification and experience than the I'll say the regular type of physical therapists that might deal with, say, sports injuries and that kind of thing. So certainly you want to have a specialty physical therapy practitioner on the team. Who have we missed? We've missed a psychologist, perhaps someone who deals with pelvic pain in general, or perhaps sexual medicine. And the patient has to be assessed fully by all the members of the team, and really to figure out what the best course of action is. So that's the first element. The second element is that the team should not be afraid to use whatever means they can to turn down the level of pain. And I think Dr. Eckenberg in his lectures has a slide where he has a sort of a volume control superimposed on the body, and he's showing a number of triggers and amplifying factors: stress, lack of exercise, certain disease, and so on and so forth, that turn up that volume dial, and to make every kind of pain much worse, and the patient much more sensitive to pain. So anything that can be done to reduce that is good. Obviously it's a very individualized kind of thing, but it should include a certainly psychological component. And again, I stress to patients, when patients call me and ask me where they should go, and I mention psychology, I don't want them to think that you need to see a psychologist because you're crazy and it's all in your head and you're making it up. That's not what this is about. And oftentimes, unfortunately, patients are told it's all in your head, you're making it up, get over it, get a life, whatever. And that's the worst thing that you can tell a patient, and it's certainly not appropriate. But it is appropriate to counsel a patient and to speak about their legitimate factors, psychological factors that can make the pain worse or better, and to really use the brain as your friend rather than as your enemy. And so that's the big difference here, that the psychologists are using the brain as the friend and not the enemy in trying to control the various situations and the triggers and the amplifying factors that make pain worse. So that's a very important part of it. Now, drugs are certainly helpful, but they have to be used judiciously, and we'll talk about, if you have time, about opioids in a moment. Opioids are good drugs, but they have a lot of downsides, and the downside is they can prolong the chronic pain state. They can make patients more sensitive to pain. So we need to try and wean patients off the opioids wherever possible, and not use them as a first resort, but use them as a last resort. There are, of course, physical therapy techniques. We've talked about those, and some of those, the physical therapy therapists can guide the patient into self-care techniques, self-massage, self-exercise techniques, or manipulation techniques that the patient can do, or the patient's partner can assist in, and those are very important. Some nerve blocks are probably quite helpful, and again, I know Dr. Eckenberg and others try and use nerve blocks very judiciously, but in a certain way, in order to help to tone down the level of activity in the nervous system, particularly in the pudendal nerve, which is the main nerve that innervates the pelvis and the genital area.
So I think we do have a little bit more time, kind of along the lines of some alternative ways of turning down the pain, and I would like you to share some information about the pain shield that you were instrumental in developing.
Okay, thank you. Okay, so let me just just give you a little bit of background. First, I'm going to show you show the viewers. This is a pain shield. It's a small device. Let's see if I've got my cell phone here. This is my cell phone. Here it is, and you can see that it's thinner than a cell phone, about the same height and about the same thickness as a cell phone. Okay, so this is the pain shield. I'm going to switch it on while we're talking so that patients can see what happens. It's a one-button operation, and it's going to boot up, and in a few seconds you'll see the display. So I'm just going to put it down. Now, just to introduce this, as we were looking at alternatives through the International Adhesions Society for things to ways to treat patients that ostensibly had adhesions, but understanding that could mean a lot of other patients as well, IC, endo, and so on. We did look at neurostimulation, and we were very interested in it, but it's expensive, and there's some drawbacks that I mentioned previously. So we were introduced to a company about a few years ago that was looking at this device, this pain shield device, for a condition in the face called trigeminal neuralgia. Now, trigeminal neuralgia is there's some nerves in the face that if they become inflamed, or if they start setting off abnormal impulses, the pain in the face can be very, very excruciating, to the point that people really want to kill themselves, and unfortunately have done so. And so it is sometimes unfortunately called the suicide disease. And so we were introduced to the company that makes this device, and that we're using it in trigeminal neuralgia. And having our understanding of what the neurological basis for pelvic pain is, we understood that there were many common links, common factors between trigeminal neuralgia and, let's say, pudendal neuralgia and other issues, IC, endo, and so on, in the pelvis. So we set about to evaluate this device in patients with pelvic pain, adhesions, IC, and so on, and we'll provide a link in a moment. But these are our data, which you can download this from the internet. But we presented these data at the International Pelvic Pain Society last year, and we had patients that had adhesions, bowel obstruction, endometriosis, irritable bowel syndrome, interstitial cystitis, and other chronic pelvic pain, and we asked patients to use this device in the pelvic area, and I'll explain exactly a bit more where they used it in a moment. But the device consists of a patch. This is a patch. It's adherent. It's self-adhesive. It comes with a backing patch here. Let me just try and show it on the camera there. Okay, and this is a sticky patch here. I'm just sort of showing the sticky part here, and in the middle of the patch is a disc. There, you see that disc there? That is a ceramic disc. It looks like it's metal, but it's this sort of oval shaped patch, and that actually emits ultrasound waves. Okay, and the idea is that the patient sticks this patch on their body. We'll show you where in a moment, and the ultrasound is emitted into the patient. It is not an electrical impulse. It is not a TENS. It is not anything like that. It is ultrasound. Now, ultrasound has been used therapeutically for many years in the physical therapy office. Those devices are high intensity ultrasound. You can only use them for 10 or 15 minutes maximum at a time. This is low intensity ultrasound. So that means you can use it for a lot longer. And it's as if the ultrasound is, I'll say, slow release in a manner of speaking. So patients wear this patch for up to 6.5 hours at a time, and the ultrasound penetrates into the body. We know that ultrasound causes warming of tissues deeply, and when it does so, the blood vessels of the muscles that it warms dilate, and blood flow is able to get to those muscles. Now, we know in all these conditions, pelvic pain conditions, muscle spasm, pelvic floor muscle spasm, is a major component. Not in every case, but it is a major component. And once the muscle goes into spasm, it closes down the blood flow to the area. When it closes down the blood flow, pain chemicals are released, which cause pain and which cause more spasm. And now you can see there's a vicious cycle going on, because pain, spasm, pain, spasm, pain, spasm. So if we can break that cycle, that's what this device is intended to do. And so we have found that patients with these various conditions were able to reduce various aspects of their pelvic pain, their painful urination symptoms, their painful intercourse symptoms, their painful defecation symptoms, and other painful symptoms. And we were so impressed by these data that we said, wow, we have to get this on the market. To us, this was a game changer. And so we invested our own money, and given the investment climate of a few years ago, and even to a certain extent till today, we realized that if we waited for investment for this to happen, we would maybe never get this device on the market. So we took the plunge and we got the device on the market. We started a new company, KevMed, to market this. Now, we're certainly not saying this is a cure-all. It doesn't help everyone. Many patients can use this. They can put it on their body, and within an hour or two they can find the sweet spot and they can start to get some pain relief. So the patient can either place the device suprapubically, either in the middle or to the side in the groin area. They could place it higher up if there's pain involved in the higher upper quadrant of the pelvis. The other place they can try this is actually where the sacral nerve comes out, which is So I hope that explains the device. You can read more on our website, kevmed.com. And we hope to help many more patients, but the key is to integrate this with your physical therapy, with the other treatments as well, and that's a key part of the overall plan. Okay?
No, that sounds wonderful. Thanks for the explanation and the demonstration of your product there, as well as the overview of adhesion, CAPPS, and how everything is interrelated. I appreciate everything that you're doing in that area, and I really appreciate the interview this afternoon. It's lovely speaking with you this afternoon. Thanks for everything.
Thank you, Carin. Bye-bye. Thank you.
Bye-bye.